Asmita? Asmita, you're there? Can you open the waiting room for the students?
Ma'am, you can start the session.
Just to wait 1 more minute. All people are just joining, then I'll start the session. Dr. Ajay, is it fine? Just 1 minute. 5:32, we'll just start. Asmita, you can put that flyer. A very good evening, everyone. So welcome to this IN Autoimmune Disorder Subsection meeting, which is being held almost every 2 weeks once. So we've had previously discussion on basic neuroimmunology. So we've started the diagnostic aspect, and today we have complete next 2 hours on neuroimaging. So I'll be moderating with Dr. Dheeraj. Dr. Rohit couldn't join us because of some emergency. So Dr. Dheeraj and myself will be moderating this session. So the first session, basically we are starting to have on initially for a neurologist as to how they should be interpreting, especially the MRIs and demyelination. The next session is going to be on specific demyelination on MS, NMO, MOG, and then the third session is going to be on the differential diagnosis. Fourth is on the immunosuppressant complications, especially when people are exposed to multiple immunosuppressants. What are the different ways we need to diagnose them? So that is what is going to be covered in the last session. So the first session we have from Dr. Ajay Garg. Can we have his CV, Asmita? So Dr. Ajay Garg is a professor and head of the Department of Neuroimaging and Interventional Radiology at All India Institute of Medical Sciences, New Delhi. Apart from demyelination, his areas of interest are on epilepsy and brain tumors. So he will be speaking on interpretation of neuroimaging. Over to you, Dr. Ajay Garg.
Thank you.
Sorry, Dr. Ajay. Dr. Rohit, you have come. You want to talk something before we start?
Hi,
Dr.
actually,
Dheeraj.
Rohit
Okay.
couldn't join, so he asked me to.
Okay, sorry. I saw the name and
That's okay. I used his link, so he had requested me to join in his.
Yeah. So shall we start, Dheeraj?
Yeah, please go
In
ahead.
between, maybe you can speak.
Sure,
Yes.
please go ahead.
Yes, Dr. Ajay. Over to you.
Yeah. Thank you, Dr. Nitra, for the kind introduction. outset, I would like to thank Indian Academy of Neurology, Autoimmune Subsection for inviting me here. Can you see my slides?
Yes, Dr. Ajay.
Today, I'm talking about the MR in CNS demyelinating disorder. How can we read and assess and interpret the MR? As you know, MR
Yes,
is
we can see you.
Asmita, you need to mute yourself, please.
MR is the most sensitive tool to pick up the demyelinating lesions. Characteristically, these lesions appear as hyperintense on T2 flare, proton density, and stir sequences. The MR can identify the lesion load, how many lesions are there, how many lesions are showing enhancement, which are active lesions. It can fulfill the criteria of dissemination in space and time for the diagnosis of the multiple sclerosis. It can also helpful for the monitoring of the treatment, and it can identify other pathology to explain the clinical symptoms. For the MR, we should do imaging in the standardized imaging protocol. Ideally, we should do MR on the same scanner in the same facility, but that is not always possible. So it's better to do standardized imaging protocol covering the full brain, consistent imaging acquisition, and we should do contiguous slices without any gap. A slice should be of consistent thickness. I'll talk about the imaging parameter. The consensus guidelines shows that for the brain, spinal cord, and optic nerve, we should do imaging in at least 1.5T scanners. For the brain, the 3D scanners are preferred. 3D imaging sequences are preferred with thickness less than 1 millimeter isotropic with in-plane resolution of 1 mm. It's better to cover the full brain. We should reconstruct these images in the subcallosal plane. For the spinal cord, also at least 1.5T scanner is preferred, and the slice thickness should be 3 millimeter or less in the sagittal plane and 5 millimeter or less in the axial planes. And we should cover the whole cord or wherever the lesion is there in the cervical or the dorsal segment. For the optic nerve, we can acquire images in 2D or 3D with slice thickness less than 3 millimeter and isotropic. And for the optic nerve imaging, we should cover the optic nerves and the optic chiasm. So what are the core sequences which are required for the diagnosis of the demyelinating disorders? There are 3 core sequences. First is the flare sequence, second is T2 weighted sequence, and third is the contrast enhanced MR imaging. For the flare sequences, the 3D acquisition is preferred. For the 3D, we acquire images in the sagittal image to reduce the time, and then we recon these images in the axial and coronal plane. For the reconstruction of these images in the axial plane, it's preferred to select imaging in the subcallosal plane, because the subcallosal plane is easier to detect than the ACPC plane, which is normally done in the radiology, because the anterior commissure and posterior commissure are difficult to identify on the flare images. The subcallosal plane images, so that images can be compared between different scanners and different timelines. These sagittal images, we can see images lesion classically in the region of the corpus callosum, pericallosal, subcortical white matter. These lesions appear bright on T2 weighted image on the flare images. So these are the reconstructed images in 3 planes, and the acquisition is in the sagittal plane. Then second core sequence is the T2 weighted sequences. The T2 weighted sequence, they are useful for the infratentorial lesions. Like in this example, this is a T2 and a PD image. You can very well see the infratentorial lesions, which are not well seen on 2D flare sequences. So wherever you are doing 2D flare sequences, we should always do T2 sequences. The slice sequence should be preferably less than 3 millimeter, and the slices should be contiguous. But if you are doing 3D flare sequences, the images quality is of good, high quality, then we may omit this T2 weighted axial sequences. Like in this example, we can see the T2 weighted sequence are showing lesion in the pons, which is very well seen on the 3D flare. On the 2D flare, we see a lot of artifacts. The images are not good for the infratentorial lesions. And third sequence is the post-contrast T1 weighted sequences, where the gadolinium is given. First thing is, after giving gadolinium, we should wait for 5 minutes. So during that 5 minutes, we can acquire our flare sequences or T2 weighted sequences. So it has been found that active new lesions, they may show enhancement up to 6 months, or preferably most of the lesions, they enhance up to 4 weeks. So the contrast enhanced MR is helpful for the identification of the new lesions. The enhancement can be nodular, it can be ring type, or it can be incomplete ring, like in this example of tumefactive demyelination showing incomplete ring of enhancement. A lesion some of the lesion may show enhancement, or some of the lesion may not be enhancing. If you see both enhancing and non-enhancing lesion, that fulfill the criteria of dissemination in space. It can confirm the diagnosis in 1/3 of CIS cases. The contrast is helpful for the initial diagnosis, but it is optional for the monitoring of the MS protocol because of the issue with the contrast of the issue of the gadolinium deposition in the brain. However, when patient is having large lesion load, where it's very difficult to differentiate new lesions, then we may give contrast during follow-up. Otherwise, the contrast is not required to pick up new lesions. This example of Tumefactive demyelination involving the medulla, where you see peripheral eccentric incomplete ring of enhancement. So here contrast is helpful. This example of this PML, where we see PML iris, where we see peripheral contrast enhancement without any mass effect. It's a demyelinating lesion, bilateral asymmetrical location. Then we have the optional sequence, which can be used for the diagnosis and monitoring. First is the diffusion weighted sequence. It is useful for the differential diagnosis. Sometimes patients present with the acute deficit. It could be because of the small lacunar stroke, which can be picked up in diffusion weighted images. Then it's a core sequence for the monitoring of the PML. I will show you the example. This example of Tumefactive demyelination, where diffusion weighted imaging is showing peripheral area of diffusion restriction, which is bright on diffusion weighted sequence, dark on ADC map. So that is helpful in diagnosis of large Tumefactive demyelination. This is an example of PML, where a diffusion weighted sequence is showing peripheral diffusion restriction, which is helpful in diagnosis. Here, if you do sequences at 1000 B value, 2000 and 3000, in case of the PML, this peripheral diffusion restriction persists even in 3000 B value scanner. That is helpful. So the PML protocol, where MS patient is receiving drug and you are suspecting PML, the diffusion weighted sequence should be done. It's a core sequence. Otherwise, it's an optional sequence. Then we have the susceptibility images, where we can see the central vein sign. We can see the thin black line of the vein. This just denotes that lesion is perivenular in location. It is most commonly seen in demyelinating lesions, but it is not pathognomic. It can be seen in other disorders also. Then SWI images is helpful for the differential diagnosis of secondary demyelinating lesions. Like this example of primary CNS vasculitis, where we see multiple punctate and macrohemorrhages which are picked up on SWI. We see punctate linear enhancement on contrast images. If you look at only diffusion, T2 weighted images, you see just a bright signal intensity. So here the SWI is helpful in making the differential diagnosis. Then we have the high resolution T1 weighted images, which is the optional sequence, which is look for the volumetry. As we have found that during MS, during follow-up, there's a brain atrophy. So this T2 sequence should be done in gradient sequence, where that sequence has a good gray-white matter differentiation. So this is 3D Bravo sequences reconstructed in different planes. A scan acquisition is less than 1 millimeter of thickness, and we can see the lesions which are also dark or iso-intense on T1 weighted images. Then we have the double inversion recovery sequence, where we give double inversion recovery, double saturation pulse, which suppress the signal of the ventricles and the white matter. It's a very good sequence to pick up cortical lesion and juxtacortical lesions, which are very bright on T2 weighted images. It's an optional sequence. This is a low resolution sequence, takes a lot of time to do. Its average time is around 6 to 7 minutes for the 3D sequences, but it's very helpful for picking up cortical lesions, which can be missed on other sequences. Then for the optic nerve imaging, we can acquire images in the axial and coronal fats at T2 or STIR sequences, where optic nerve will appear bright signal intensity, and contrast can be done in axial and coronal fat cell sequence. Like in this example, in the STIR sequence, we can see increased signal intensity in the optic nerve, which is going posteriorly into the intracranial part of the optic nerve, and this is showing contrast enhancement on post-gadolinium T1 weighted images. The advantage of axial images is look for the extent of optic nerve involvement, whether the anterior segment is involved, posterior segment, that can be picked up on these axial slices. Then for the spinal cord sequences, we should do at least 2 sagittal sequences out of T2, PD or STIR. Out of these 3, at least 2 sequences should be done, because in the spinal cord we see a lot of artifacts. So to reduce the artifacts, it's better to do at least 2 sequences. The example of PD and T2 weighted sequences, where we'll see multifocal short segment bright demyelinating lesions involving the cervical cord. In the cervical cord, we can replace these sequences from the PSIR sequence. This is a T1 3D sequences where lesion will appear hypointense. So at least 2 sequences should be done. The slice thickness should be 3 mm or less. There should be no gap between these slices. Then we can do axial sequences on the whole cord, hollow cord, or maybe through the lesion, where we can see the horizontal extent of the lesion, whether the lesion is involving the full thickness or partial thickness of the cord. Then how to interpret the MR images? First, we should exclude lesions which are less than 3 mm in size, especially when the lesions are located in the subcortical white matter of the frontal lobe. Then we should try to localize the lesion, whether lesion is periventricular, cortical, juxtacortical, thalamic, or infratentorial. Then what is the size of the lesion? The lesion more than 20 mm are called tumefactive demyelinating lesions. More than 6 mm are large lesions, whether the lesions have the mass effect. The most of the demyelinating lesions don't have commensurate mass effect. How much is the number of the lesions? Whether number of lesions is increasing during follow-up. Whether lesion is showing diffusion restriction. If there is a diffusion restriction, whether it is peripheral or central. What is the enhancement pattern? Whether it is showing nodular enhancement, peripheral enhancement, incomplete ring of enhancement. And during follow-up, we should look for any new lesions, which are bright, new T2 lesions, new enhancing lesions, or sometimes the T2 lesion enlarge in size. So we should look for the enlarging lesions, and we should monitor for the PML. I'll show the example. First, the location of the lesion. The periventricular lesions, they're periventricular lesions commonly seen in supratentorial compartment, are they lesion about the lateral surface of the in contact with the lateral ventricle, or sometimes rarely the third ventricle. But if the infratentorial lesion is abutting the fourth ventricle, we don't call it periventricular lesions. They are just spinal cord, this is brainstem lesions. Then we have the cortical juxtacortical lesions, which are located in the cortical gray matter or in the juxtacortical abutting the cortical gray matter structures. But they are not separated from the gray matter by the normal white matter. They will abut it. This is to differentiate from the subcortical lesions, where the subcortical lesions, they are separated from the cortical gray matter from the by the normal white matter structures. So they don't contact with the ventricular surface, or they are not contact with the cortical surface. Then we have the corpus callosum lesion. Most of the corpus callosum lesions, they are they abut the inferior ependymal surface of the corpus callosum. They rarely involve the full thickness of the corpus callosum. They are usually seen in the medial 2/3 of the corpus callosum. Sometimes we can see the lesion within the center of the corpus callosum, which is classically seen in Sudak syndrome, which involves the middle layer of corpus callosum. So whenever you see corpus callosum lesion, try to see what is the location of these lesions, whether it's involving the full thickness, involving the ependymal surface, abutting the ependymal surface, or whether they are central in location. Then we can have the basal ganglia or thalamic lesions into demyelination. Whether these lesions can be symmetric, asymmetric, they may show enhancement. Sometimes the white matter lesions abuts the gray matter structures, then we don't call it thalamic or basal ganglia lesions. The thalamic or basal ganglia lesions are centered around the deep gray matter structures. Then infratentorial lesions are best seen on your T2 vegetative sequences. They are peripherally located towards the surface. They are abutting CSF surfaces like peripherally of the brainstem or towards the fourth ventricle. They are better seen on this T2 sequences. Then we have the lesion which are periventricular in location, can be ovoid in location because of their orientation along the perivenules. Then we can have the tumefactive lesions, which are large. They will show peripheral rim of T2 hypointensity, which will show contrast enhancement. They don't have any commensurate mass effect. They are more than 2 cm in size. Most of the Taj tumefactive demyelination lesion will show open ring type of enhancement, but sometimes when they are small in early stages, they may show complete ring type of enhancement also. Then we can have the black holes, which are appearing bright on T2 weighted images, dark on T1 weighted images. These lesions don't enhance on contrast. If lesion is enhancing on contrast, we don't call it black holes. These are the chronic lesion, and they are more associated with chronic debilitation. Then we can have the concentric sclerotic lesions, where we see multiple layered appearance of isointense, hyperintense lesions. These are because of multiple episodes of remyelination and demyelination. They are classically demyelinating lesions. Then whenever you see analyze the optic nerve, we should analyze whether the unilateral optic nerve is involved, bilateral optic nerve is involved, whether short segment or long segment of the optic nerve is involved, whether it is involving the anterior segment, posterior segment of the optic nerve, or both segments, whether chiasm is involved or not. Is there any enhancement? If there is enhancement, what is the enhancement pattern? Do you see peri-optic nerve sheath enhancement, or is there any fat stranding around the optic nerve? So these are helpful feature in differentiating various causes of optic neuritis. Like in this example, we see long segment optic nerve involvement, both sides, there is a bilateral peri-optic nerve sheath enhancement. So we should look for this pattern of involvement. In this example, we can see involvement of this posterior segment of the optic nerve, unilateral involvement only on one side. Then the spinal cord, whenever you analyze the spinal cord, always first thing is to rule out artifacts. Whether lesion is single or multiple, whether it's involved in the short segment, long segment, or in the horizontal sections, whether it is eccentric, central, or involving the full thickness of the cord, or what is the enhancement pattern. Like first thing is whether it's really a lesion. Sometimes because of the Gibbs artifacts, sagittal image shows linear artifacts, linear area of hyperintensity, which mimicking like a syrinx or maybe a long segment of spinal cord involvement. They are mainly seen in the phase encoding direction. We can reacquire the images using the higher metric size to reduce these artifacts. Second is the flow artifacts, where you see flow artifacts mainly seen in the dorsal region. This should be mistaken for the vascular flow voids, but these are CSF flow artifacts. They are larger, they are not well defined, commonly seen in the dorsal region. Then whenever you see the extent of longitudinal involvement, whether the spinal cord involvement is the short segment, multiple, or long segment involvement, or whether there is involvement of the area posterior of the medulla or not, or whether you see multiple bright lesion within the white matter lesions, like what we call it bright spot is saying. So you should look for all these findings to differentiate various causes of spinal cord involvement. So these are the short segment involvement and long segment involvement, and then look for the pattern of enhancement on this. So to conclude, we should do the standardized MR imaging protocol for detecting brain lesions acutely. The three main core sequences are 3D FLAIR, T2 axial, and post-contrast T1 weighted images. In the spinal cord, we should do complementary sequences between T2 SAG, T2 PD, or STIR sequences. Or if when you are doing spinal cord imaging, we can replace one T2 sequence with the PSIR sequence, which is a T1 weighted sequence where lesion will appear hypointense. In initial diagnosis of workup of patient with CIS, it's better to give contrast for the imaging of the brain and spinal cord to pick up enhancing lesion to help in making the diagnosis of multiple sclerosis. Then the contrast should be used judicially during routine follow-up of the patient and should not be used during pregnancy. Thank you.
Thanks a lot, Dr. Ajay. It was a very lucid, nicely you covered about all the different type of sequences and the artifacts. Very nice. Dr. Dheeraj, you would want to.
Yeah, hello, and thank you, Ajay. It was quite an interesting and quite well detailed protocols that you discussed. And I think imaging, as we all understand, is not just diagnostic. It is a very important modality for delineating different disorders, as well as on follow-up. It helps us for decision making for the treatments too. So with this, I think let's go to the next lecture by Dr. Sameer Vyas. He is going to be talking of specific disorders and the role of MRI in CNS demyelination. So Dr. Sameer, he is currently a professor at the PGI Chennai. He's a colleague of mine at PGI, and he has his areas of interest in neuroimaging and CNS infections and has over 190 publications.
Dr. Dheeraj, if it is fine with you, there's one question in the chat box which we can ask Dr. Ajay to answer before Dr. Sameer starts. There's 5 more minutes. Is it fine?
Yes.
Okay, sure.
Yeah.
So we have, are there any newer imaging modalities in MS? And there is one, how to differentiate white matter lesions of neurometabolic disorders and demyelinating disorders, considering T2 and T1. I think this would be taken up by maybe Samir is going to be talking of different disorders. So this second question. So any newer modalities, I think, Ajay, if you could take that question up.
Yeah,
Newer imaging modalities in MS.
yeah. In multiple sclerosis, we can do diffusion where there's a DIR sequences, then MT sequences to pick up the lesion load. Now we are doing more and more 3D sequences in this, even in the spinal cord. We are doing 3D sequences so that we don't miss any lesions. But everything this adds time. For a routine protocol, it's better to stick to the core sequences. For a research environment, yes, we can do more, much more.
So how do you differentiate, for just an additional question to this? You have a follow-up of a patient as well as, or a patient who has presented to you for the first time. Do you distinguish between the protocol on a follow-up versus the baseline?
Yes, follow-up, we don't do SWI sequences because we know that it is not it's a multiple sclerosis lesion. Then we try to avoid contrast if it's not required. At least the thing we do.
So you're not looking at, so how do you make out activity then? Because I know I read some, there have been a lot of talk on
We try to look for if you see a new lesion on T2 weighted sequences or lesion which size is increasing.
Okay, all right, got it.
Rohit is quite
Maybe you could
particular.
also tell us something on the neurometabolic disorders distinction of, because many times, this may look like a dysmyelinating lesion.
Yeah, neurometabolic disorder mostly bilateral, more or less symmetrical rather than a focal lesion, which we see in demyelinating lesions.
Right.
And the history will be long based on this. Bilateral symmetrical involvement more in favor of this dysmyelinating lesions.
Okay, I think we can now move on to the next talk by Dr. Samir Vyas. Samir.
Thank you, sir, for the kind introduction. So I will be discussing the MRI in specific CNS demyelinating disorders, MS, NMO spectrum disorders, and MOG associated disease. Over the last 3 decades, with advancement in technology and wider availability of the MRI, it has become the most essential imaging modality to evaluate any disorder involving the CNS, because it's a high sensitivity, non-invasive, and we are able to visualize lesions in the brain, and the optic nerve, and the spinal cord. So as in other disorders, the role of imaging is early and accurate diagnosis, more important location and extent of involvement, and excluding the mimics. I will be discussing the imaging spectrum of these disorders in brain, optic nerves, spinal cord. I will be highlighting the typical lesions, few of the MRI signs which are associated with these disorders, and briefly touch the atypical lesions as they are the frequent mimickers, how to distinguish them from these disorders. Imaging protocol has already been discussed by Professor Ajigar very nicely, so I will skip these slides. So after a good acquisition, since the T2 hyperintense lesions, what we are seeing is a frequent diagnostic dilemma, and these are only cardinal features in demyelinating disease. So how do we approach these lesions? Though MRI is highly sensitive, but it has a very low pathological specificity, because these lesions, the T2 hyperintense lesions, may be seen in the edema, inflammation, demyelination, remyelination, and as we're discussing, neurometabolic disorders, gliosis, and neuroaxonal loss. So these have a non-specific and cover a very wide variety of pathological entities. So how do we approach? The first and foremost is looking for the location and the pattern recognition. In a location, look for the site of the lesion. In the white matter, as discussed, look whether they are the periventricular, deep white matter, subcortical white matter, or juxtacortical white matter. In gray matter, whether they are in the cortex or involving the gray matter structures, and try to characterize whether it's a striatum involved, whether it is a thalamus involved. Look the brainstem, whether it is a peripheral brainstem involved or the central brainstem involved. and then look the lesions, the cerebellum, white matter, or the cortex, and then see the further size, as discussed by Professor Ajay, whether they are less than 3 mm or non-specific lesions, 3 mm or more, which are more suggestive of a demyelinating with oval or round in shape. More than 6 mm, they are large demyelinating lesions, and more than 20 mm refer commonly as a tumefactive demyelinating lesion. Then look for the shape, whether they are well-defined, ill-defined, or fluffy, and then enhancement, whether it is a nodular enhancement, as seen in small demyelinating lesion, incomplete ring enhancement, which are very characteristic of the demyelinating disorders, a complete ring, or a heterogeneous or other pattern of enhancement, which we will be subsequently discussing in various disorders. There are various MS phenotypes. I will be discussing the radiologically isolated syndrome, which is pertinent to neuroimaging. So RIS refers to the MRI finding of demyelination in the absence of the clear symptoms consistent with the demyelination. Incidents of RIS have significantly increased over the years because of the wider use of the MRI in evaluating various neurological disorders. Like this is frequently used in evaluating epilepsy, trauma, various type of headaches. So incident has significantly increased. The risk of conversion of clinical definitive MS is estimated to be approximately 19%. The imaging factors which are associated for the conversion are presence of gadolinium enhancement on index scan and presence of the spinal cord lesion on MRI in the initial scan. The diagnostic criteria of RIS was first given by Okuda et al. In 2009, and now it is revised by Labram Fran et al. In 2023. It has incorporated most of the imaging criteria of the modified McDonald's 2017 criteria. In this criteria, the following features have been adopted. The MRI with the incidental CNS white matter anomalies demonstrating radiological characteristic highly suggestive of demyelinating disease and meeting the following criteria. Avoid well-circumscribed lesions more than 3 mm square with or without involvement of the corpus callosum. Involvement of the characteristic sites of the MS, periventricular, cortical, juxtacortical, infratentorial, and spinal cord, and anomalies inconsistent with the microvascular or non-specific white matter disease pattern, with exclusion of the clinical criteria suggestive of the demyelinating disorder. In MS, I will begin with discussing the 2017 McDonald criteria. So I will be highlighting the two important criteria in neuroimaging, that is dissemination in space and dissemination in time. Dissemination in space refers to two or more lesions in out of these four locations: periventricular lesions averting ventricles, juxtacortical lesions averting cortex or cortical lesions, infratentorial lesions, and spinal cord lesions. The dissemination in time, the DIT, refers to the new T2 hyperintense lesion irrespective of the timing of the baseline scan and presence of simultaneous enhancing and non-enhancing lesion on MRI. The typical location of the MS lesion is supratentorial, what in approximately 10% of the patients, infratentorial lesions are also seen, and they are more commonly seen in children. The cortex and the basal ganglia involvement may be seen in up to 10% of the cases. The shape is usually ovoid or round shape, and as discussed, they may show a nodular, open ring, or closed ring enhancement. We have to identify the lesions which are characteristically periventricular in location. So periventricular refers to the lesions which are averting the ventricle located in the white matter. The lesions which are involving the deep gray structures like the caudate head or the thalamus do not refers to the periventricular lesions of the MS, and lesions those are in the deep white matter and not averting the ventricles, and there is intervening white matter, are not referred to as characteristic lesion of the MS. Such lesions which involve the deep gray structures or deep white matter are more commonly seen in ischemic small vessel disease. Similarly, confluent lesions involving the subcortical white matter in the temporal lobe or the deep white matter are more seen in the vasculitis like CADASIL, and lesions which are involving the central part of the corpus callosum are commonly seen in the Susac syndrome. Similarly, the isolated lesions are seen in the deep white matter are non-specific white matter lesions, and we should not label them as periventricular lesions in the MS. Similarly, symmetrical frontal horn capping or the occipital horn capping should not be included in the periventricular lesions of the MS, and neither they should be included in the lesion count to assess the lesion load in MS. Small punctate lesion less than 3 mm are non-specific and cannot be categorized as the periventricular lesions of the MS. The typical cortical lesions in MS are best seen on the double inversion recovery sequences, and they are located in the cortex, the bilateral cerebral hemisphere. Juxtacortical lesions refers to those lesions which are averting the cortex. The lesions which are in the subcortical white matter and there is intervening white matter between the cortex and the lesions are not specific to the MS lesions. Similarly, we should be careful in differentiating the prominent VR spaces from the lesions of the MS. The infratentorial lesions in the MS are more commonly located along the periphery of the brainstem or the peduncles, and they are not located in the center of the brainstem. So lesions which are involving the center of the brainstem like midbrain or pons are more suggestive of the ischemic small vessel disease, and the lesions which are around the fourth ventricle, mainly around the ependyma or around the periaqueductal, are more suggestive of the NMO spectrum disordered lesions rather than the MS. Similarly, confluent fluffy lesions involving the midbrain and thalamus, mesothalamic lesions are more suggestive of the MOGAD spectrum, which I will be discussing. There are many signs described in the MS. I'll be discussing the few. The central vein sign has been discussed by Professor Ajay Garg also. It refers to central T2 hyperintensity. In a T2 hyperintense lesion, the central hypointensity should be less than 2 mm, should be visible in at least 2 planes, and it should not occupy more than 50% of the space. There is a North American imaging criteria in the MS in which they have concluded that it should be visible in at least 2 perpendicular MR plane. Another common sign which is seen in the early stage of the disease is the ependymal Dosdat sign. Along the calloseptal surface, what we see is alternating points of dark and light, and they refers to the earliest involvement and perivenular demyelination. The dorsal finger sign, which is commonly seen, refers to the periventricular MS lesions, which are oriented perpendicular to the lateral ventricles. The open ring sign or horseshoe sign refers to all the demyelinating diseases, and what we see is a open ring type of enhancement. We see a T1 iso to hypointense lesion in the MS in both acute stages and in the chronic stages. In acute stages in the MS, they refers to demyelination or the inflammation. What we call a black hole is the lesions which are chronic, that is more than 3 mm, and they may be seen in approximately 30% of the initial lesions of the MS. They are associated with more destructive pathology, more axonal loss. In a pediatric multiple sclerosis, the lesions are more commonly located in the occipital periventricular white matter, followed by the frontal periventricular white matter. Cortical and deep gray matter lesions are less commonly detected. So in MS, we see the site of the lesion, we look for the morphology of the lesion, enhancement pattern, and then we see optic nerves and spinal cord, which I will be discussing. So it's a typical case of MS, a 31-year female who present with the relapsing remitting symptoms. What we see on imaging is a cortical lesion involving the two adjacent gyri. There are lesions in the periventricular white matter averting the lateral ventricle. There are lesions along the periphery of the brainstem involving the pons, midbrain, and there are the lesion involved juxtacortical lesions. There are lesions in the subcortical white matter and along the periventricular white matter, which are oriented perpendicular to the brainstem, which are better seen on T2 SAG images. We should carefully evaluate the lesions, infratentorial lesions, which are along the periphery of the brainstem. They may show a diffusion restriction or a variable pattern of a contrast enhancement. In MS, the optic nerve involvement may be the first clinical manifestations in 20 to 25% of the patient in MS, and approximately 50% of them will optic neuritis at some point during the course of the disease. So what we see in MS is unilateral involvement, usually a short segment of the optic nerve, predominantly the intraorbital portion is involved. The variable pattern of the contrast enhancement and disease and the diffuse restriction may be seen depending upon the stage of the disease and disease activity. The spinal cord involvement may be seen in around 85% of the cases in early MS. Commonly, the pattern is 3-piece, that is, the lesions are patchy. Patchy means they involve less than the 2 vertebral segments. They are peripherally, they are located along the periphery of the cord, and they are posteriorly located. They are more commonly seen in the cervical cord. So 3-piece, you have to remember for the MS, typically patchy lesions along the periphery and a short segment. There are various red flag signs to discriminate the MS from the other disorders like cerebral venous sinus thrombosis. We see hemorrhages, meningeal enhancement, cortical infarcts, and the calcification. We should think of the alternative diagnosis in place of the MS. Similarly, sometimes in elderly, it's important to discriminate the small vessel disease from the vessel disease from the multisclerosis. So depending upon the involvement of the particular site, we should be able to discriminate the small vessel disease from the MS, like the corpus callosum involvement, the infratentorial involvement is more commonly seen in the MS. In monitoring the disease activity for initial scan, gadolinium contrast enhanced MRI is indicated, and dedicated spinal cord and optic nerve should be evaluated. In a follow-up scan, gadolinium is optional, and it depends upon the clinical indication and the symptoms. Similarly, the spinal cord MRI should only be done if clinically indicated. The lesion load in MS is an important for assessing and prognostication. So we can do it by counting the total T2 hyperintense lesions and the 3D flare or double inversion recovery sequences by looking the lesions at the characteristic site of involvement, the periventricular lesions, juxtacortical or cortical lesions. In addition, we should also have a count of the other lesions which may not be specific for the MS, but contribute to the lesion load in MS, like D white matter lesions, the black holes, the involvement of the optic nerves, and brain atrophy. With this, I will move to the NMO spectrum disorders. In imaging, what we see is multifocal lesions involving those regions which are rich in aquaporin 4 regions, like the periependymal surfaces of the lateral ventricle, periependymal surfaces of the third ventricle, optic chiasma and the periaqueductal area, and periependymal surfaces of the fourth ventricle and the area postrema. What we see is the multifocal lesions which are of a variable shape and a various pattern of enhancement is seen. In optic nerve involvement, the optic nerve is involved, usually bilateral involvement is seen more extensive, and optic chiasma involvement is seen more commonly. So what we see is a bilateral involvement of the posterior part of the interorbital segment of the optic nerves, and also there is involvement of the optic chiasma. So bilateral posterior with involvement of the chiasma is more suggestive of the optic nerve involvement in NMO spectrum disorders. In spinal cord involvement, what we see is the longitudinal extensive transverse myelitis involving more than the half of the total area of the spinal cord, and maybe sometime a hollow cord involvement may be seen, and more commonly involvement is of the cervical cord. A patchy striate enhancement may be seen involving the NMO spectrum disorder, and it's usually seen in the acute stage. In 2015, criteria for NMO spectrum disorders in imaging contribute significantly. In cases of acute optic neuritis requires one of the following: brain MR imaging showing normal finding or only non-specific white matter lesions, optic nerve MR imaging showing T2 hyperintense lesion or T1 gadolinium enhancing lesion extending over more than 1.5 of the optic length or involving the optic chiasma. In myelitis, it requires the longitudinal extensive transverse myelitis extending for 3 or more contiguous segments, or spinal cord atrophy, which is contiguous and involving 3 or more segments. And in the brain, the area postrema syndrome, on imaging, what we see is the involvement of the dorsal medulla, and in acute brainstem syndrome, what we see is the periependymal brainstem lesion. Here is a 12-year female with a myelitis and a diagnosed case of NMO spectrum disorder. What we see is the entire involvement of the cervicodorsal cord. On axial images, we are seeing more than 50% of the area of the involvement of the upper spinal cord. There is a patchy enhancement in the spinal cord with more leptomeningeal congestion, and there is involvement of the bilateral optic nerves more on the left side. The brain lesion in these patients are non-specific, and there is a patchy involvement of the corpus callosum posteriorly and averting the surface but not transgressing across the midline. Another patient of NMO spectrum disorder that we see here is the optic neuritis on the right side, and there are patchy lesion in the cord transgressing the dorsal cord. It's a long segment involvement, and there's suggestion of the mild cord atrophy, or in a brain, there are diffuse, extensive involvement of the white matter. In addition, there is involvement of the ependymal surfaces along the third ventricle, around the periaqueductal region. There is involvement of the periventricular white matter and around the periaqueductal region of the periependymal region of the fourth ventricle. Then there are few signs which are described in the NMO spectrum disorders, like arch bridge pattern of splenian involvement. It refers to the lesion in the splenium of the corpus callosum, which has a concave posteriorly, refers to the arch bridge pattern, and it is more commonly seen in the NMO spectrum disorders. We may see a cloud-like enhancement of the corpus callosum lesions. Then other signs described. These are suggestive but not specific for the NMO spectrum disorders, like marbled pattern of the corpus callosum involvement. We may see a pencil-thin enhancement of the ependym of the lateral ventricles. Then in a LETM, what we see a bright spotty sign, the signal intensity of the involvement of the cord, which is equal to or more than the surrounding CSF. And then there is a string signs, which refers to the diffuse long segment atrophy of the cord. Then I will be discussing the MOGAD, myelin oligodendrocyte glycoprotein associated disease. The clinical phenotype of MOGAD varies with the age. The presentation of ADAM are more frequent in a pediatric population as compared to the aquaporin 4 NMO spectrum disorders, in which the ADAM-like presentations less commonly seen. The brain lesion in MOGAD are found in approximately 42 to 53% of the patients. The typical MR lesion location are periventricular white matter, involvement of the deep gray structures, thalamus, basal ganglia, involvement of the brainstem, involvement of the middle cerebral peduncle, involvement of the cortex. So the imaging pattern is a very heterogeneous. The characteristic lesions which are more suggestive of the MOGAD pattern are involvement of the deep gray structures like thalami, middle cerebral peduncles, diffuse involvement of the pons, the peduncles. The lesions are typically poorly demarcated and fluffy in appearance. The recently international MOGAD panel proposed criteria, and imaging plays a very important role. So in a supporting clinical or MR imaging features in optic neuritis refers to the bilateral simultaneous clinical involvement, longitudinal optic nerve involvement, perineural optic sheath enhancement, optic disc edema. In myelitis, what we see is a longitudinal extensive myelitis, more common involvement of the lower cord, and the conus lesions are very suggestive of the MOGAD. In brainstem and cerebellar, multiple ill-defined lesions, which I have discussed. A flame is a clinico-radiological subentity of the MOGAD. What we see is a focal cortical encephalitis-like picture of the changes along the cortex unilateral with the leptomeningeal congestion and enhancement. But we have to keep other differential diagnoses like viral encephalitis and MELAS in the differential diagnosis. In optic nerve involvement, what we see is a long length involvement of the optic nerve, more commonly involving the anteriorly the optic nerve head and the intra-orbital segment, and we may see a perioptic fat enhancement in cases of the MOGAD. In spinal cord involvement, what we see is the longitudinal extensive transverse myelitis, more commonly involving the central gray matter involvement, and conus involvement is more frequently reported in the MOGAD patients. We're showing the MOGAD patients, a 3-year male child, fever, headache, and inability to walk since 2 weeks. So what we are seeing is a multifocal lesions involving the middle cerebral peduncles, brainstem, involving the cerebellar white matter, no diffusion restriction, no susceptibility changes, no contrast enhancement. There are lesions involving the posterior limb of the internal capsule, the thalamus, and then the subcortical white matter. So these lesions in a clinical setting are very suggestive of or typical of the MOGAD. Another patient, bilateral symmetrical lesions in the pons, middle cerebral peduncle, and transgressing to involve the cerebellar white matter. HG diffusion section, no enhancement, and there are cortical lesions and lesions involving the deep gray structures. Again, very typical of the MOGAD. Another patient with the right optic neuritis, we have optic neuritis involving the anterior part of the left optic nerve. Here, what we see is a bilateral symmetrical involvement of the periventricular white matter, which is referred to as a leukodystrophy-like pattern of the MOGAD diseases. This pattern is less commonly seen and carries a poor prognosis. In a MOGAD, a sign described is a axial H sign, and what we see a classical involvement of the spinal cord in a H-shaped manner, central gray matter involvement, but this sign is also seen in a NMO spectrum disorder. The differentiating points between the MS, MOGAD, and NMO spectrum disorder is cortical lesions, juxtacortical lesions, and periventricular lesions are more common in the multiple sclerosis. The corpus callosum lesions, deep gray matter lesions, and diffuse middle cerebral peduncle, pons lesions, and leptomeningeal lesions, as discussed, are more common in the MOGAD. The lesion in the corpus callosum, the subcortical white matter, non-specific lesions are more common in the NMO spectrum disorders and lesions which are along the periependymal surfaces. Now, there are many imaging criteria which help in predicting the prognosis and carries the poor prognosis, like in MS, the cortical lesions, high number of the lesion, the gadolinium enhancing lesions, and in a MOGAD, the leukodystrophy pattern, which I have discussed, and in MO spectrum disorders, persistence of the gadolinium enhancement and reduced hippocampal volume. To conclude, MRI play a very pivotal role in diagnosing and disease monitoring, as MRI helps in delineating the distinct features associated with these conditions. The clinical criteria of demyelinating diseases, all the revised criteria modified McDonald's criteria 2017 as the criteria of the RIS as well as the MOGAD rely heavily on the imaging with MRI. So they help in early and precise diagnosis. The main neuroimaging marker are localizing the lesions and then characterizing the lesion based upon their configuration. Thank you.
Thank you, Samir, for this extensive account of the different demyelinating disorders. And actually, since like you mentioned, MOGAD is still evolving. We are still learning a lot about MOGAD, and newer patterns are emerging. And even the criteria which were recently described, they seem to be evolving too. So we do have a lot of difficulty sometimes in distinguishing NMO and MOGAD, especially when the antibodies are not positive in quite a few cases. So I think, do we have some time for the questions, Netra?
Yes, some 2-3 questions at least we'll take. Thank you, Dr. Samir. We very nicely brought about, especially the periventricular, the UBO, and the vascular lesions, because sometimes just the location adjacent to the periventricular, they get diagnosed as demyelination. I think very nicely brought about. One of the question to you is, if there are no brain lesions, how to differentiate GFAP myelitis from MOG myelitis?
The characteristic pattern of the enhancement is only in a GFAP. What we see is the stride pattern of enhancement with the overlying meningeal congestion. So pattern of enhancement is the differentiating point.
Okay. What about the enhancement pattern? Does MOG lesions enhance or not enhance on contrast?
It depends upon again the disease activity. They show all the demyelinating show lesion depending upon the stage of the lesion at what time we are imaging them. But in a like GFAB astrocytopathy, what we see is a typical stride pattern of enhancement, which is not seen in the MOGAD lesions. So in MOGAD lesions may show a peripheral or incomplete rim, but the GFAB lesions show a more stride pattern enhancement.
Then one more question from Dr. Akshay. How to differentiate autoimmune encephalitis and MOG on imaging?
This is a relatively good question, sometimes very difficult. So in a autoimmune, the leukoencephalopathy is less likely. What we see in a MOGAD in a pediatric patients, what we see is a limbic pattern, then a striatal pattern, then what we see is a cortical pattern. But a typical multifocal pattern is not seen. What we see in a autoimmune is a more bilateral symmetrical leukoencephalopathy. So such lesions are not seen, but recently there have been report of the few cortical lesions in autoimmune also. So by recognizing the pattern of involvement, what it's seen in a pediatric patients is a striatal or a limbic. So that helps in discriminating.
Thank you, Dr. Samir.
Thank you.
We'll go to the next talk now. The next talk is on differential diagnosis of CNS demyelination, and this is by Professor Jitendra Saini, who is a professor at National Institute of Medical Health and Neurosciences. And in his CV, he has put that he specialized in movement disorders and brain tumors, but I feel he's also most of the time neuroinfections and demyelination is also his specialty. Over to you, Saini.
One second. Okay. Are you able to see my
No,
slide?
Saini, it had come that time, it went off.
Sir, you can reshare your screen.
Okay. 1 second. No, actually, now I'm not getting that.
Close your slideshow, sir. Slideshow PowerPoint close.
I have closed that one.
Yeah, go back to the Zoom window. Alt tab, use Alt tab and go back to the Zoom window. Hello.
Hello.
Yeah, go back to the Zoom window, sir. And there is the option of a share screen.
That Zoom window only I'm having a difficulty.
Saini, it came and went, so maybe you need to close it and again try to reshare.
Okay, 1 second. Hmm. That window is okay. That window is not getting enlarged for me. That's the problem. Shall I log in again?
Hello.
Hello?
Yeah, can you hear me, sir?
Yeah, I can hear you.
Yeah, go back to the Zoom window, sir. Have you able to see the Zoom window?
Oh, that window, I'm not able to now. Somehow I just.
Yeah, so close your PowerPoint, sir. Close your PowerPoint.
No, it is not related to the PowerPoint. Shall I again log in with this one?
Yes, that's a better option. Logged out again. Logged in again. Sir, put it on slideshow mode.
Are you able to see? Are you able to see it now?
Yes, sir, but it in editing mode. You put it on slideshow.
Okay, fine. Is it okay?
Yes, sir, perfect.
Okay, fine. Sorry for the glitch. So, thank you, Dr. Netra, and all the organizers for the webinar for giving me this opportunity. So, I'll be talking about CNS demyelinating diseases. Already, Dr. Ajay and Dr. Samir has spoken amply about all the common disorders, but I'll talk about some about the mix. Um, so, so these are the primary demyelinating disorders, as already been mentioned in the previous, and there's some uncommon forms of those demyelinating disorders. And then other causes like which can mimic it is from the infections, autoimmune encephalitis, ischemic lesions, and these are the various demyelinating disorders already have been described. So I'll start with the variants of primary demyelinating disorders, which can present with an atypical imaging appearance like Bell's concentric sclerosis, Schilder's disease, and a Marburg MS. So this is a typical case of Ballous concentric sclerosis. You can see that there's an hyperintensity on both sides of the cerebral hemispheres, and you can see that there's some sort of pattern or circular rims you can see concentrically present, and the central part of the lesion is showing a lot of necrosis, and you can see that as we go towards the periphery of the lesion, trace images of the diffusion imaging is showing some hyperintensity. There's no bleed within these lesions, and they are present on both sides of the and when we give a contrast, you can see that's broken rim appearance, which is very typically seen here. And usually the non-enhancing part comes towards the ventricular margins, but it can show ventricle, and it can also show enhancement like in this location. And when we look at the perfusion, they can be mimicked. When they are single in location, single lesion is present, then they can mimic a tumor or a metastasis. In that case, we do a perfusion imaging, and you can see the low perfusion in these lesions. Spectroscopy depends upon at what place you are doing a spectro. You can see that as we move from the center towards the periphery of the lesion, the center has got a lot of necrosis. You will see a large lipid peak. And as we go towards the periphery, we'll start seeing a larger choline peak because there's a lot of inflammation present. And Na will be markedly down because Na reduction is virtually absent in the center of the lesion because there's a remarkable amount of destruction present in the center. So if you extrapolate it to the tumefactive lesions, they look very similar, and tumefactive demyelination seen in these are the features you might be knowing. The most important thing is that they have some characteristic pathological features like prominent Creutzfeldt-Peter cells and dystrophic astrocytes, which demarcate them from the typical MS lesions. And we also need to know that fingolimab and netlizumab should be avoided in these patients presenting with the tumefactive lesions because they tend to aggravate these lesions and even trigger tumefactive lesions when they are initiated in MS patients or when they are withdrawn in the MS patients. And you can see this is typically, and one interesting feature about these lesions is that the lesion, the most necrotic part of the lesion tends to go into the subcortical U fiber. You can see it here, and in the subsequent scan, you will see a cyst forming in this particular location. Again, you can see the peripheral rim of trace hyperintensity, which is showing diffusion restriction. And when diffusion restriction is present, they tend to show enhancement more often as compared to those which are not showing any ADC hypointensity. And this is another case. You can see that here, as I mentioned, that as we move from the periphery to the center, you can see how as we are going towards the center, we are seeing large lactate and lipid peaks coming into the picture, whereas Na is coming completely down. But as we go towards the periphery, we can see that Na is slightly present, but choline is much markedly elevated in this particular location. And you can see the patches of diffusion restriction coming here. As they evolve, how they evolve, and when they evolve, actually you can see that the lesion shrinks in size, the cyst forms, and there will be remnant signal changes present in the hemisphere depending upon the size of the lesion. And on T1 metered images, you can see the hypointense areas within the. And a remarkable thing is that Na makes a significant recovery in this one. So this is not totally a destruction of neurons, which leads to the Na reduction. There's some sort of other metabolic dysfunction happening, most likely mitochondrial dysfunction, which is happening, which transiently leads to the decrease in Na, which gets recovered subsequently. And also we can see that an RSWI images initially the lesion looks very bland, but later on you can see remarkable iron deposition happening in the surrounding structure, especially basal ganglia. Here basal ganglia were totally unremarkable, but you see it in the subsequent scan, you can see a lot of iron deposition happening. In Eve also the subcortical rim also starts showing iron deposition in these cases. It is not only associated with the MS, other lesions. These kind of tumefactive lesions can also be present with the other named entities. Like for example, in this particular case, you can see a left periventricular lesion is present with a large tumefactive pattern, and you can see the fluffy enhancement, as Samir has mentioned. This kind of fluffy enhancement is a feature of NMO. This is a case of NMO with a tumefactive lesion. You can again see the diffusion restriction coming in the peripheral part, or the part which is showing enhancement. So it's not only the morphology about the lesions that it should always be coming in the peripheral. It can be in these other lesions, the restriction or the part showing trace hyperintensity can vary in its location because they are not typically cystic lesion with the peripheral rim enhancement. So, so in summary, they can be associated with the other neuroinflammatory disorders such as neurosarcoidosis and Behçet's, but in my own experience, I have rarely seen. I will show you one or two cases of this one. Now coming to Schilder's disease also shows tumefactive lesions, which are pretty large, and they just mimic the tumefactive demyelination, but they tend to affect the frontoparietal region with the corpus callosal involvement, but the cortex, cerebellum, brainstem, and spinal cord are relatively spared. So this is one of the features of coming to the Marburg MS. Again, Marburg MS is a rare variant. It's a monophasic illness usually. And there was a Neurology 2024 article which deals about all the published cases of Marburg to the MS, and this data I have taken from there. So one of the points here is that clinically they respond poorly to the conventional acute treatments, leading to, and they have a very bad outcome, can lead to death also and they respond very well to cyclophosphamide. So clinical information along with the imaging. Imaging will show tumefactive large lesions distributed in both cerebral hemispheres, but the clinical information will help us to understand it's a Marburg. And they have pathologically they show extensive macrophage infiltration, massive demyelination, axonal injury, leading to overt necrosis and cavitation, as I have shown in the tumefactive demyelinating lesion. Just now there was a discussion about GFAP astrocytopathy. I have not seen really any case of proven GFAP, but what I can understand is that it has a very specific imaging pattern in which there is a linear enhancement. This I have taken from literature. You can see there's a linear enhancement of the going from the ventricular wall towards the periphery. And this characteristic radial perivascular enhancement is characteristic of GFAP astrocytopathy. So this has got a specific imaging features. This image slide I have taken from the Twitter page of Leah. She happens to be a editor at AGNR, and she has very nicely summarized. It happened today only, and she says that a short segment optic nerve involvement is a feature of MS. This kind of M kind of lesions or Dawson fingers in the brain or the corpus callosum, and the subcortical lesions here. And the spine can show less than 2 segment involvement, small lesions means. Whereas in NMO, posterior nerve gets involved, then all the areas around the ventricles, means like look at here around the 3rd ventricle, around the 4th ventricle, and the aqueduct, and the long segment involvement, more than 3 segments, with a lot of destruction and enhancement, fluffy enhancement in the spinal column. And in case of MOGAD, perineural enhancement is characteristic, and then you can have lesions in the posterior fossa, which can involve the 5th nerve course as well as the cerebellar white matter, brainstem, and H-shape involvement with the conus involvement in the spine. Now coming to another lesion, look at this particular case. Sometimes you can encounter, like this particular case, there's an extensive enhancement here. You can see there's a bright signal coming in the spinal cord, and there's a lot of enhancement. So this enhancement pattern of this extensive enhancement and this enhancement pattern reminiscent of somewhat on trident sign. So we thought it might be sarcoidosis, but it turns out to be NMO or echopurin 4 was positive in this particular case. So sometimes they can mimic other lesions. Sarcoidosis is one of the lesions which they can mimic and which typically involves the cervical cord and can show this pattern of enhancement. But we need to be aware that it's not always 100% the patterns. Then there are the other demyelinating disorders, certain other patterns like which includes ADEM, AHE, and ANE, and SSP, HIV, PML, which are associated with infections. You can see this is a ADEM, which happens after the vaccination or a viral illness. You can see that's again tumefactive lesions are present, which can show enhancement. Again, the central area of remarkable destruction with the surrounding rim of T2, which is intermediate between the totally CSF or a normal white matter, and which peripherally merges with the normal brain parenchyma. And this characteristic rim on the trace, always look at the trace image, this characteristic rim of hyperintensity. Look at the small lesions also showing that one, which actually tells us that this is a demyelination. I'll give you a value. I'll show you some cases where it will be, you can understand what is the value of this sign. Acute hemorrhagic encephalomyelitis is a very rare form, but it has got a devastating results in terms of clinical outcomes. Here, demyelination is associated with a lot of hemorrhage. For example, in this particular case, you can see it's a remarkable amount of hemorrhage, which is leaking into the ventricles as well. And then extensive signal changes present to the cerebral white matter. So it's a rare form of disease where demyelination is accompanied by a lot of hemorrhage and very difficult to diagnose, because hemorrhage and demyelination do not usually go hand in hand, and it is fatal, but some patients do survive also. Acute necrotizing encephalopathy has a characteristic pattern that it can involve rest of the brain also, but the most important thing is it involves symmetrically thalamic structures and can involve brainstem as well. For example, in this particular case, brainstem is getting involved, and it has got can show central necrosis also here, which shows susceptibility and a diffusion restriction in the peripheral areas. There's another case where diffusion, where the hypointensity is coming in bilateral thalamus and showing diffusion restriction, and somewhat of hemorrhage is coming. So this is a specific pattern. Look at the hepatic dysfunction. They tend to show a very high SGO2, SGPT. It was initially described in Japan, but later on we have seen cases in India as well. It's associated with the influenza viral infection. And you can see another entity which can be associated with the infections is this particular case. You can see confluent symmetrical white matter signal changes. They are not showing any enhancement. They are very unremarkable. Another case where you can see the periventricular signal changes coming here. So this is a case. So in an appropriate background, these signal changes become important. This is a case of HIV encephalopathy. Usually it tends to be symmetrical and periventricular in location, can be extensively confluent, does not show any enhancement. But the other differential diagnosis in HIV patient can be this presence of the PML infection, which leads to this kind of tumefactive lesions. Here, corpus callosum is getting involved in the splenial region. T1 hyperintensity is there, and you can see trace hyperintensity. Again, look at the trace hyperintensity in this particular case. T1 is unremarkable. There's no enhancement coming here. But in case of after starting a therapy and recovery in CD4, you can iris patients can show enhancement in these patients. Another infection which can show periventricular hyperintensities, which have a substrate of demyelination is SSP. This another case. You can see confluent white matter signal changes going. And you can see the brainstem is getting involved. Basal ganglia can get involved. You can see a lot of susceptibility setting in, just like in a tumefactive demyelination cases I showed previously. On T1, again, they are it's hypointense lesions. They do not enhance, but they can show diffusion restriction, especially in the basal ganglia regions when the lesions are present. This is another case where confluent white matter signal changes are present. Some amount of asymmetry is present, but so they require a clinical information and background. They cannot be diagnosed radiologically. Coming to other infections which can mimic a primary demyelinating illnesses like Whipple's. So Lyme's disease is one entity which can have a scattered white matter signal changes. Syphilis, brucellosis is another entity which we should be aware of. I'll show you some of the, and rickettsia and leptospirosis are other diseases. I'll show you some examples. So this is a neurobrucellosis. These are some of the cases published by my colleagues from neurology. You can see this is a case of which has a confluent periventricular white matter lesions which simulate or demyelinating illness, and but some thalamic involvement is also there. So there are some red flags. Spinal cord is also getting involved, and they are not showing any enhancement here. So there's a case of rickettsial encephalitis, which we have recently diagnosed many cases. They can also show scattered hyperintense lesions on FLAIR images, which are not in any vascular distribution. One of the remarkable thing about them that they show a lot of diffusion restriction, and they can involve corpus callosum as well as periventricular white matter. But in an appropriate setting, we can make this diagnosis of rickettsial encephalitis. Sometimes scans can be normal. They can show meningoencephalitis or this particular pattern of disease. Another entity which can come with a lot of white matter signal changes is the varicella-zoster encephalitis, because it has got when it involves the small vessels exclusively, then it can just show scattered white matter signal changes. But when it involves the large vessels, you can see a lot of infarcts being present, which can be very patchy in nature. For example, this particular case, the MR angiogram gives you a clue when all the vessels, especially the supraclinoid ICAs and the MC and ACAs, are getting stenosed or showing very attenuated appearance. Other vascular, so these entities, especially rickettsia and the varicella-zoster, tend to involve the vessels. That's why so other vascular diseases include vasculitis, SLE. They can also, because they affect the vessels, they can also cause white matter signal changes. These are just various entities which can included in this particular. This is Takayasu arthritis. You can see that large vessel occlusion is there and the signal changes are there. But sometimes you can see some of these entities presenting in a very, very bizarre white matter signal changes, which can be very tumefactive in nature. And the post-contrast enhancement pattern will give you the clue that here, for example, look at the enhancement pattern, which we normally don't see in the tumefactive demyelination. It's more linear going, and some confluent large enhancing areas are also seen. So, and in this particular case, again, it is not that overt here, but some signal changes are present in the brain parenchyma, but they are away from the ventricles, but they can be present in the ventricular location. So these are tumefactive form of vasculitis, which you can see then one focal area is showing a lot of signal changes here. And these are signal changes present opposite side. Actually, there was another scan before this particular scan happened, which showed the signal changes were much less. But then again, enhancement pattern gives you a clue. Presence of hemorrhage gives you a clue to the diagnosis. Coming to APLA, which is another vascular disorder, which can show scattered white matter hyperintensities, which can be subcortical as well as, but they are not in the corpus callosum, the periventricular location most often. So this is another, it's a SLE, which can be associated with a frank stroke, but can also show scattered white matter hyperintensities. For example, in this particular case, you can see juxtacortical as well as some of the white matter hyperintensity present in the gangliocapsular region, and some are showing some amount of gliosis around them. You can see this is the brainstem involvement in SLE, very ill-defined expanded lesions. Then toxic leukoencephalopathy is also there. You can see this is related to the drug intake, mycophenolate, leading to the periventricular signal changes, which is showing diffusion abnormality also. So, but this is more confluent. This pattern is seen in another condition. I'll show you in some. So central vein sign is very specific to MS. It was mentioned by Dr. Ajay and Samir, but what I understand is that it is seen more often in MS or a demyelinating lesion, but it is not exclusive to the venocentric distribution of lesions. Most importantly, it is seen in all types of MS clinical phenotypes, and it is also seen in other primary demyelinating disorders of the vein of the brain. But it can also be seen in the small vessel disease and systemic disorders like SLE and Bisset syndrome. So we should not think that it can help in differentiating in a given case, but it's more often seen in cases of demyelination. Others are PRESS, PML, which are all PML. I've already shown you a case. Then another entity which is important is Sjogren syndrome. I'll show you some cases of Sjogren syndrome. You can look at the white matter signal changes, spinal cord involvement in this particular case. And in this particular case, you can see there's an extensive involvement in the periventricular location. Sorry. And not much microhemorrhages are there. So in these kind of cases, just don't look at the imaging patterns. We need to look at the clinical aspects also to get the correct diagnosis. Look at here corpus callosum lesions in a case of Sjogren syndrome, and here cord is getting involved in a case of, you can see the extensive necrotic lesions within the cord in case of Sjogren syndrome. Drug-induced vasculitis, another entity which we must be aware of. In this particular case, he was a actually drug abuser. We don't know what exactly led to this, but he was taking multiple agents of abuse, and you can see this radiating pattern of white matter signal changes, extensive microbleeds present. They are all showing diffusion restriction, and there was some sort of enhancement present in some of the lesions, and there was some sort of enhancement in the meningeal space as well. So sometimes we need to look at these aspects also. Only the imaging pattern is not enough. For example, in this particular case, Behçet's disease is the Behçet's disease, which has characteristic involvement of the cerebral peduncle, midbrain, and the thalamic region. In this particular case, you can see some diffusion abnormalities coming in the internal capsules, and right side cerebral peduncle is expanded. There is no specific imaging features, but just the distribution of the lesions in this particular area. Whipple's disease also tends to involve these areas, but then the clinical features of hypothalamic dysfunction and presence of hypothalamic abnormality can give you a clue. Sometimes doing an ultrasound abdomen to look at the lipid-rich nodes is also useful in those cases. This particular case on follow-up imaging shows regression of those signal changes, partial regression of those signal changes, and subsequently you can say very little is left. Coming to another entity which can present with the extensive white matter signal changes. Look at this particular case. You can see extensive signal changes present in the brainstem, temporal lobes, and the enhancement gives you a clue that what is it. Then you can see the extensive enhancement going around the anterior commissure, going into the corpus callosum, going into the gangliocapsular areas. And this patient actually underwent a biopsy. It's a case of Clipper. We suggested and underwent a biopsy because there's always a possibility of a lymphoma in these cases. Overall, afterwards, you can see there's some regression of the signal changes. Enhancement has completely disappeared. You can see enhancement has completely disappeared. Signal changes have regressed a bit, but they still can be seen. Sarcoidosis, I mentioned the cranial nerve enhancement is one of the features, but can show a lot of abnormalities of white matter. They can show, for example, this is a pure parenchymal lesions. Extensive cord involvement can be seen, as I showed you in another case. This is my images from my friend, Dr. Batla, who works in University of Iowa. Then other conditions which can have problems, which can have a demyelination as a includes osmotic demyelination. They have a symmetrical involvement in the pons as well as in the basal ganglia, but can show a lot of white matter signal changes. In a context, we can actually make a diagnosis. Osmotic demyelination. They can have middle cerebral peduncle lesions called splenial lesion, as well as brain cerebral parenchymal lesions in atypical forms can also be seen and can show diffusion restriction. So coming to Wernicke's, that has got a very characteristic involvement of mammillary bodies and the hypothalamic region, which gives you a clue, and the periaqueductal white matter, which gets, and also the history of alcohol intake, though non-alcoholics can also show Wernicke's encephalopathy. Coming to another interesting entity which can have a periventricular confluent white matter signal changes can be present and can show diffusion abnormality is a vitamin B12 deficiency, though not all cases will have this brain parenchymal finding, but we must be aware of this possibility because it is a very treatable condition. And spinal cord involvement, you already know what is the pattern in these cases. Copper deficiency, another gives you a mimic of B12 deficiency. Again, spinal cord involvement and same areas of involvement can be seen. Tumors is another entity which can actually look at this particular case. This is a case where you see, look at the signal changes here. There was a doubt whether it is a tumor or it's a demyelination. And actually look at this. I looked at the diffusion. I suggested that it looked like a demyelination, and it turned out to be an NMO positive case. But this particular case initially presented with this particular lesion here. Thalamic involvement was there, which should have given us some clue. Yeah, I was not sure. I thought we can wait for some time and just see whether how it evolves. It didn't respond to steroids, and particularly you can see the subsequent scan after some months. It has grown a bit, and now actually after that we can see now there's a massive tumor present in the same case. So sometimes we should it is very difficult in the initial phases sometimes to discriminate these lesions. Midline glioma high grade with CSF spread now. Similar problems can happen in the spinal cord. In this particular case, look at the cord, which is very expanded, very focally expanded, showing enhancement, can mimic a demyelinating lesion, especially the NMO. But this kind of, you can see the spared cord here, and there's an expanded lesion present there. So it gives you, so careful reading of images can give you a clue. Sometimes it's very difficult to discriminate. I think the clinically, such a large lesion with a relatively preserved patient should give us a clue that it's a tumor, whereas a smaller lesion with a lot of clinical deficits in spinal cord can gives a clue that it's some demyelination. So this case was a case of spinal ependymoma. Another entity which can mimic is a lymphoma. In this particular case, you say extensive signal changes are present, and then follow-up imaging. There was no enhancement in the beginning, but subsequently started showing enhancement. So these are some of the problematic cases where we are not very sure. Another case which is very interesting is that you can see extensive signal changes in the posterior fossa periventricular location. This was a child had problems for a very long time and had these abnormalities, which were, and this very bizarre looking enhancement pattern. So this is a case of lymphohistiocytosis. I've seen many cases of lymphohistiocytosis. So one of the clues here is that look at the always when you're looking at a histiocytic disorder, look at the possibility of involvement of dentate nucleus, and also look at the sinuses. If there is a sinuses with the mucosal thickening which is appearing T2 hypointense, think about a histiocytosis. Ardeen-Chester tends to show that. So these are some of the clues here. We had got the clue from this posterior fossa involvement, and they can show all sorts of patterns like degenerative pattern, enhancement, which can be very bizarre. Today also I saw a case, I haven't put it, but it was a very similar looking case. So this is an interesting case, which fever, headache, tingling sensation. This was a lesion present in the right thalamus. I had some doubt when I looked at this diffusion scan, because there was again a peripheral rim which is looking slightly hyperintense, but I was not sure it can be midline glioma. There was no hyperfusion. It remained like that. Some shrinkage of lesion on the follow-up scan, and subsequently a surgical biopsy was done, and which led it's a demyelination of the right thalamus. So this part will be taken care by the next speaker. But I'll just show you some of the interesting cases which I have encountered. This particular patient had signal changes here in the bilateral occipital lobes. So this is a case of press, which is showing a facilitated diffusion. This is a typical case of press. Whereas in this particular case, you can see there's a signal changes coming in the bilateral, asymmetrical signal changes in the basal ganglia, some signal changes in the white matter. So sometimes it can have a atypical imaging appearances also. This is a 20-year-old male with a severe headache, loss of consciousness, worked in a lead acid factory, had very unusual kind of signal changes present, which are also showing diffusion restriction. Sometimes MOGAD can have this kind of cortical, subcortical involvement, but this particular patient had a lead associated encephalopathic features, which led to this thing, and blood examination was useful in making a diagnosis. This is another case which can show extensive signal changes. Again, a lead case. You can see the calcification is giving you a clue. Cortical calcification, that's a lead-induced signal changes. So not only demyelination, there are so many other entities. This is an interesting case where history of this happened. The husband and wife were in the same place, and they both were found unconscious after they were using a gas deezer, and this was so initially they were fine, but then the husband developed a lot of cognitive problems. MR was done, and it showed this periventricular signal changes, which were showing diffusion restriction. You can see that this thin rim of diffusion. So this is a post-hypoxic demyelination, which happens after a cardiac arrest, or in our context, after a gas geyser incidents. A vascular disease like DAVF can also show signal changes, like in this particular case. This is a DAVF patient. SWI images gives you a clue. Lot of vessels on T2 weighted images, and this kind of bizarre looking venous structures will give you a clue. Angiogram will clinch the diagnosis. It's a case of DAVF. Migraine is another entity which can lead to white matter signal. This is a very interesting case which I saw in my MD time. Patient used to have aura, and we used to do an MRI, and there was a signal changes. And every time this location used to get changed from its previous location, and diffusion used to be positive. This scattered white matter signal changes, which changed position, can be seen in migraine. So we must be aware about this particular entity as well. Thank you. So in conclusion, demyelination inflammatory diseases, they can a wide variety of entities apart from the primary demyelinating diseases. Imaging plays an important role, but clinical context is very important. And I would like to thank Dr. Netra and my colleagues from Department of Neurology for giving me feedback on these cases, and my colleagues and students in Department of NIR who always discuss and lead us to the correct diagnosis. Thanks a lot.
Thank you, Dr. Saini. Very good collection of lot of cases and giving us good insight. We have few questions. Dr. Dheeraj, you will take up the questions for Dr. Saini.
Yeah, sure. Thanks, Dr. Saini, for an excellent educative description of so many cases and so many conditions. So we have a couple of questions. There are some of them I think have been previously answered. So one question, which I think may be specifically directed towards Dr. Saini, is: can neuromyelioidosis mimic demyelinating disease?
Yeah, it can mimic because it can have a slightly chronic course, but then they tend to form abscesses. So that will give a clue. And but another clue there is that it involves a brainstem and can involve fifth nerve as well as involve corticospinal tracts and can go across the corpus callosum. So the pattern of involvement can give you a clue. But what I understand is that usually it's more patient will be more sick and will be a more of an infectious picture, whereas the infections which I have spoken about, like Lyme's disease and neurobrucellosis, they may not look like an infection cases. They can just mimic a demyelinating illness. And similarly, the Sjogren syndrome, which I showed, was actually being treated like a MS for a very long time, and both can respond to steroids. So that can be an overlapping point. But it was a lip biopsy proven case. So that's what I'm saying, that in a clinical context, I'm just saying that all these entities can mimic. I agree. If you look at the MR, it can mimic. I agree with that point.
Sure. And I think this question, we could take it again. Have you seen the autoimmune encephalitis mimicking MS? If so, which ones could actually mimic autoimmune encephalitis?
I wouldn't say that they will mimic MS, but I would say they can mimic tumefactive lesions of a demyelination. But again, the clinical context is when they have present with the large lesions, usually patient will have they will be much more symptomatic and in a different fashion. So I haven't really this discussion we never had, that whether it's an autoimmune encephalitis or versus a demyelinating lesion. But yeah, when will have a large lesions and they tend to involve more of a white matter, then you can have actually that doubt.
And I think the clinical correlation will also give us quite.
Yeah, so all these cases, what really gives us a clue is that they all is that in a context when we see them, when there's a context to it, we can actually make a diagnosis. Sometimes radiologists can give a clue that okay, this lead encephalopathy, both cases actually I could make out that yeah, one showed a cortical calcification, which is a diagnostic of lead. Another case which showed very vague signal changes. That's one of the features which I've seen. Those who take some of the Ayurvedic medicines which are actually contaminated with lead, they can lead to. So doing a lead levels in that case helped us.
Okay. Thank you. And so I think we could. There's one question. We had a case of multiple demyelinating lesions, and only COVID was found positive. So is there any experience that you have had with COVID-related ADEM lesions?
Yeah, Dr. Netra has published actually one series on COVID-related post-COVID demyelination. So it's like an ADEM. What happens in a ADEM that you have an infection, throat infection, and then subsequently have lesion. So it happened with the COVID also. Dr. Netra can actually highlight more about it. I was I was also a co-author in that paper.
Great. So I think we could take the next talk, and maybe at the end we could take the rest of the questions. Netra?
Yes.
Thank you.
Thank you, Dr. Saini.
Thank you, Saini. Thank
So
you.
with this, we go to our next speaker. Our next speaker is Dr. Smiley Sharma, who is going to be talking on the MRI of immunosuppression complications. She's faculty assistant professor of neuroradiology from the Shri Chitra Institute at Trivandrum, and she was trained in neuroradiology at AIIMS Jodhpur, and she's been faculty at Shri Chitra for the last few years, and she has published numerous papers, as well as she's got numerous memberships as well as research projects to her name. So over to you, Dr.
Thank
Smiley.
you, sir. Thank you, sir, for the kind introduction. Is my slide visible, sir?
Yes, it was visible.
Now, after the interesting talk, we'll move on to the next topic, that is the MRI of immunosuppression complications. One second. So first of all, we'll discuss about the complications of therapies for multiple sclerosis and demyelinating disorders, because per se the talk today is relating to demyelination, and the most primary disorder which we'll discuss is PML. And we'll also discuss about the complications of immunosuppression or immunocompromised status per se, like HIV, to discuss about the various opportunistic infections or associated neoplasms that can happen due to immunosuppression. So immunosuppression is basically the impairment of the body's immune response. It affects the body's defense mechanisms to prevent diseases. So this leads to increased propensity to the opportunistic infections and certain cancers. The main causes include the iatrogenic ones like immunosuppressive therapies, chemotherapy, radiotherapy, as well as the immune disorders, the most common being HIV/AIDS, as well as chronic illness. In context of demyelination, the immunomodulatory and the immunosuppressive therapies for multiple sclerosis are associated with increased risk of infection, and which makes the treatment of this condition challenging in daily practice. So we'll first look at the various drugs that are used for treatment of multiple sclerosis. In the acute status, we usually use glucocorticoids, IVIG, and plasmapheresis, and then we use disease-modifying treatments, which include injectables as well as oral and intravenous disease-modifying treatments. So the immunosuppression caused by these drugs can lead to various opportunistic infections, but although the number of opportunistic infections can be associated with them, but they are not as common as seen with other immune disorders like HIV. The most common disorder which we will discuss is PML, which is caused by JC virus, and it is not only caused by the well-known letalizumab, but also by some other drugs like fingolimod or dimethyl fumarate. So progressive multifocal leukoencephalopathy is basically a demyelinating disease that results from the activation of the JC virus, which infects the oligodendrocytes in a patient with an immunocompromised status. In context of HIV, usually the patients will have a CD4 count of 50 to 100 below it, and the clinical presentation will vary depending upon the parts of the brain involved. Their various phenotypes include the classic PML, which will usually not have the patients will not have that much immune activity to show contrast enhancement or mass effect, to inflammatory PML, which is intermediate between the classic PML and PML iris, which is a condition in which the immune response increases and there are changes of inflammatory response as well in the context of PML. There can be iatrogenic PML by the drugs causing immunosuppression, as well as PML may remain asymptomatic in many patients with immunocompromised status. The PML typically spares the optic nerve and spinal cord. So whenever we are imaging for monitoring or for screening for PML, so we need not do optic nerve and spinal cord imaging. Amongst the various etiologies of PML, the most common one is HIV, followed by various hematological malignancies, various drugs used for transplant recipients, hematological disease. And in context of MS disease-modifying drugs, they constitute about less than 5% of the causes of PML. The common drugs are natalizumab, dimethyl fumarate, fingolimod, and rituximab. The AN consensus criteria have given, they suggest that either we can do a pathological diagnosis of PML, or more commonly, we can use a combined clinical and imaging criteria along with the CSF PCR for JC virus. So the definite PML is when all the three criteria are positive. Probable one is when JC virus is present in the CSF PCR, but either of the two features, that is clinical or imaging findings, are positive. And possible PML is when either the imaging and the clinical features are positive or the JC virus is positive, but not both. And not PML means when only either clinical features or imaging findings are positive and the other corroborative features are negative. So we'll start seeing the features of PML by looking at this case, who was a 43-year-old male, and he did not have positive, like we did not know about the HIV status at the outset. This patient came to us with a query of whether it is PRES or ATEM. So we can see multiple confluent T2 flare hyperintense lesions, which are reaching up to the subcortical white matter and gray white matter junction and involving the U fibers. And we can see that the lesions are T1 hypointense. They are asymmetrical on the both sides. And when we see the diffusion weighted image, there is diffusion hyperintensity at the leading edge of these lesions with facilitated diffusion within the core of the lesion. There is no blooming in this case. And looking at the rest of the parts, we are able to see that these lesions are confluent, present in frontal parietal lobe as well as in the occipital lobes. They're also involving the insula and the thalami. And as we see further, there is also involvement of the middle cerebellar peduncle. So these are typical features of PML, which are multifocal, confluent or patchy, bilateral, but they are asymmetrical white matter hyperintensities, which are usually present in the having a peripheral predominance, that is the subcortical predominance, but there can also be a periventricular involvement. They are T2 hyperintense and they are hypointense on T1. They commonly involve the subcortical fibers, and the common regions involved are frontal, parieto-occipital regions. They, despite the size of the lesions, have little or no mass effect and little or no peripheral enhancement in case of a classic PML. Thalamic involvement is common, and basal ganglia, brainstem, and cerebellum can also be involved. And in later stages, even gray matter can be involved. There are various signs which have been described in PML. For example, when we look at the T2 image, if we zoom the image, we'll see this granular appearance with like small T2 hyperintensities within the T2 hyperintense area. So this is commonly seen in PML. Then we have this sign of involvement of the cerebellar white matter. So this sign resembles the shape of a shrimp. That is basically, it is involving the middle cerebellar peduncle and cerebellar white matter with the sparing of the dentate nucleus. So this sign is known as shrimp sign. And in one of the studies by AJNR, it was found that shrimp sign is usually present at the onset of the clinical disease. So it may be an early sign of the disease and can help in resolving the diagnostic dilemmas. But most of their patients were on the background of HIV. Only one patient was having rituximab-associated PML, but that was also positive for shrimp sign. So we need larger studies to see whether this sign can be positive in drugs like immunomodulator drugs associated PML or not. The other sign is, this is the case of the PML, and here we see that there is involvement of the corpus callosum, which is spanning towards the towards the occipital regions, and there's also the shrimp sign present here. So this involvement with adjacent confluent white matter hyperintensities resemble the shape of a barbell. So this is known as barbell sign. Then another sign which has been described is like, especially in cases of chronic PML, there will be a susceptibility weighting imaging. We'll see a linear blooming along the gray-white matter junction. So this basically indicates neurodegeneration and maybe because of the iron-laden macrophages. So apart from the classic PML, now we come to PML iris. That is a condition in which there is immune reconstitution. So whenever a patient, in context of MS drugs, a patient is stopped on, if patient is having PML on natalizumab, and we have to treat the patient, we'll immediately stop the drug and start the plasmapheresis. So this may lead to a paradoxical increase in the immunity of the patient, and this will lead to an increased inflammatory response. So this results in the increase in the size of the lesions. And what is seen on feature which is not seen in classic PML, that there is more of contrast enhancement, and there are multiple small satellite lesions apart from the main lesions, which is known as the Milky Way sign. They also usually show punctate kind of post-contrast enhancement. Then coming to the topic proper, that natalizumab associated PML, how is it different from the PML associated with HIV? So in natalizumab associated PML, it is commonly seen that the lesions are usually punctate or very small lesions, and the Milky Way sign present in the PML iris can also be seen associated with it. And they usually show contrast enhancement about 30 to 40% cases as compared to the classic PML. And these enhancements will be either rim-shaped or linear-shaped or very punctate kind of enhancements. So this is the case of natalizumab-associated PML, where we can see that there are multiple small satellite lesions surrounding the main lesion that are punctate in shape, and this is the Milky Way sign. And we are also able to see multiple small punctate lesions in case of natalizumab-associated PML. So the main features to differentiate between HIV-associated PML as compared to natalizumab-associated PML is that mainly the lesions are punctate in case of natalizumab-associated PML, and there may be more commonly showing enhancement as compared to HIV PML, which does not show enhancement except in the case of iris PML. So PML iris is different from natalizumab-associated PML in that it will also show edema, it will show increase in the size of the lesions, and it will show mass effect, which may not be present in the natalizumab-associated PML. The differentials of PML include HIV, AIDS, and encephalopathy in context of HIV, where we see atrophy of the brain, and as compared to the asymmetrical bilateral hyperintensities, we have symmetric bilateral hyperintensities involving predominantly the periventricular and the deep white matter with sparing of the subcortical U fibers, which was seen commonly involved in PML. On T1 weighted image, there we saw that there will be T1 hypointensity, whereas in this case, there will be a T1 isointense signal. The other differential in context of MS drugs, which we should know, is like if we are following up the patient, there may be new MS lesions, and they have to be compared, whether these are new MS lesions or they are PML lesions. So the features which favor towards PML are the large size of the lesion, the predominant subcortical as compared to the periventricular involvement seen in MS lesions. And usually the PML lesions will be irregular and having an ill-defined infiltrating edge, whereas the MS lesions will usually be well-defined in shape. And PML lesions, as like other PML features, will not show mass effect, will usually not show contrast enhancement. And once they are become, like earlier, they will maybe iso-intense on T1, but slowly they will progress. They are progressive lesions, and they will keep on becoming hypo-intense on future follow-up. The other differential in the context of white matter changes can be pressed, but the clinical history and the pattern of involvement is quite different. As well as ADEM, there will be a different clinical history, example, recent vaccination or infection, and they can involve both gray and white matter, and the lesions usually enhance in case of ADEM. So this is the consensus criteria for like what protocol we should follow. Already Ajay sir has told that diffusion weighted image is one of the core sequences for PML follow-up. And the basic sequences which we have to use is 3D flare and axial T2 weighted sequence and diffusion weighted sequence. Usually for screening of PML, we do not require the optic nerve and the spinal cord imaging. And for screening and for follow-up of MR, the contrast is usually not required. However, it may be done if the patient is symptomatic or if the lesions have increased in size. So this is the criteria for follow-up of MR in case of MS cases. Whereas when we are monitoring for PML, when we are screening PML, contrast is not required, and PML screening is done in annual MR brain through annual MRI brain. Now, if we find PML lesion on T2 weighted sequence, then we have to give contrast to see the pattern of contrast enhancement. And if once the PML is diagnosed, for follow-up, we have to keep the patient on contrast enhanced like MRI. The normal criteria for follow-up in case of PML screening is annual screening. However, if patient is being on treatment with natalizumab more than 18 months, or patient is having certain risk factors that makes him a high-risk patient, then we have to do frequent 3 to 4 month screening. Spinal cord MRI is not required. And there is another criteria, like suppose we are stopping a drug because of the complications of PML, then at that time we have to do one MRI. And then further, if the drug was natalizumab, we have to do MRI 3 to 4 months till 12 months. So the high-risk patients for PML include the patients who were on natalizumab for more than 18 months, as well as those who are on prior immunosuppressive therapy, and those who have anti-JCV antibodies present in them with a titer of more than 1.5. So what is the rationale for doing this follow-up is that many of the patients having PML with natalizumab may be asymptomatic. However, the natalizumab associated PML, if detected, has a lower mortality as compared to HIV associated PML. So if we do regular screening, we can catch up these asymptomatic cases, and this will help in improving the survival rate of the patients. Also, JCV antibody is an important marker to indicate whether the patient is at high risk or not. So every 6 monthly JCV antibody detection is recommended. So concluding the protocol, that in case of routine MS surveillance, we'll do an annual scan to look in patients of low risk of PML. But if patients are having a higher risk of PML, then we have to do a scan at every 3 to 6 months. We can use an abbreviated protocol, that is FLAIR, T2, and DWI. And in patients like we have to switch from one drug to the other, we should take a baseline scan. And if the drug was natalizumab, then we have to do frequent MRI follow-up. So after PML, we'll just briefly discuss about few of the opportunistic infections which can be seen with these drugs, as well as an immunosuppressed status. HSV encephalitis can be seen with drugs like fingolimod and IV disease-modifying agents. As we all know that HSV encephalitis can be seen involving the temporoinsular lobe as well as the cingulate gyrus in an asymmetrical pattern with SWI, with blooming on SWI, suggesting hemorrhagic encephalitis. Now, other opportunistic infections, we can quickly look in the context of HIV, plus also we'll discuss some of the drugs which can cause these infections. So CNS toxoplasmosis, usually it is the common etiological agent for focal CNS disease in patients with AIDS. So what do we see is, we see multiple targetoid kind of lesions having rings of hyper and hypointense signal. That is the target sign, which is pathognomic of toxoplasmosis. Usually the lesions are multiple in number and involve the basal ganglia thalami commonly, as well as they can involve the gray white matter junction. They can also be an eccentric rim enhancement with an eccentric nodule, which is known as eccentric target sign. Now, this is another case where we were able to see small targetoid lesions, and we are able to see that there is some peripheral enhancement. This patient came out to be positive for toxoplasma antigen. This is another case where we are able to see small targetoid lesions and which are showing ring enhancement. The patient was considered to be having TB, but later on we suggested that patient can be a patient of toxoplasmosis, and the patient was found to be positive for that. Then the other common DD for toxoplasmosis is primary CNS lymphoma. In primary CNS lymphoma, the lesions are usually larger and they show diffusion restriction, and usually the location is in the subependymal location or involving the corpus callosum as compared to basal ganglia thalami seen in the toxoplasmosis. Now, HIV-associated primary CNS lymphoma is more aggressive than in immunocompetent patients, and they may show hemorrhage as compared to the immunocompetent patients. DWI shows diffusion restriction, and the contrast enhancement seen in them can be a necrotic pattern, without having homogeneous contrast enhancements as compared to the patients with immunocompetent status. So the differences between toxoplasmosis and CNS lymphoma include that usually CNS lymphoma is of larger size, and the enhancement can here also be ring in a context of immunosuppressed patients. Usually it involves corpus callosum or periventricular white matter, whereas toxoplasmosis involve basal ganglia, thalamus, and subcortical white matter. The lesions can be multiple or solitary in both. And on thallium scan and PET scan, CNS lymphoma is hypermetabolic as compared to toxoplasmosis, which is hypometabolic. Now, the fungal infections can be seen with various immunosuppressant complications. One of the fungal complications which is commonly seen with HIV is cryptococcus. In context of MS drugs, it can be seen with fingolimod or glucocorticoids. Now, cryptococcus can present with meningitis or can lead to formation of pseudocysts or cryptococcomas. Now, on imaging, we see either meningoencephalitis or we can see intraventricular or intraparenchymal cryptococcomas, which usually will not show diffusion restriction, and usually are they seen in the basal ganglia, thalamus, and cerebellum. In addition, we can see gelatinous pseudocysts, we can see hydrocephalus, and we can see that there will be, what important feature we have to see is that there will be multiple VR spaces. For example, in this case, we are able to see non-enhancing VR spaces in the frontal white matter. And on the contrast enhanced FLAIR image, we are able to see subtle enhancement along the sulci. This patient was positive for cryptococcal antigen. So TB, we all know that is one of the common diseases in case of immunosuppression. It can occur secondary to natalizumab and glucocorticoid treatment. So we all know the features of TB. It can lead to especially basal meningitis with lot of basal exudates. It can lead to obstructive or non-obstructive hydrocephalus. Obstructive in this case caused due to adhesions. It can lead to cranial nerve enhancement as well as lead to the hydrocephalus with surrounding periventricular hyperintensities. And there can be involvement of the caudate vena nerve roots leading to arachnoiditis as well as a granuloma, which is seen in this spinal cord in this case. The TB granulomas can be caseating or non-caseating. In this case, this is a T2 hypointense granuloma showing a peripheral enhancement. So this is a caseating granuloma with solid center. Whereas if the center is hyperintense with a hypointense rim, it will be a caseating granuloma with central liquefaction. Whereas non-caseating granulomas will usually be hyperintense on T2-weighted image. We have discussed about PML iris. Similar to that, especially first it was described when we give an ART treatment to patients with HIV. So there may be paradoxical deterioration of the clinical status as the CD4 count rises. So the patients may have increase in the manifestation of different diseases. For example, this is a follow-up image of the patient. Previous image is not shown here, but the patient was not having these many granulomas as seen in this patient. So this was a case of iris secondary to ART treatment. The last infection which we can discuss is CMV infection. In context of MS drugs, it can happen secondary to glatiramer acetate and glucocorticoids. It typically involves the ependymal lining, and then it can lead to ependymitis, ventriculitis, or it can also lead to meningitis, and especially it can lead to retinitis. So if there is retinitis, there is a 10-fold chorioretinitis, there is 10-fold increase in the ventriculitis in these patients. In this case, we are able to see that there is ependymal diffusion restriction and subtle enhancement, and there was also chorioretinitis with choroidal detachment on the right side. So in conclusion, immunosuppression predisposes to multiple opportunistic infections, and we have to use, we are using multiple drugs for treating MS and other demyelinating diseases. So we have to use an interdisciplinary approach and individual stratification of treatment-related infections complications so as to manage these patients. And as we discussed, PML is an important complication of immunosuppressive therapy, and secondary to natalizumab has a more punctate appearance and contrast enhancement as compared to those on background of HIV. I want to thank Indian Academy of Neurology, Dr. Netra ma'am and Dr. Shruti ma'am for giving me this opportunity. I also want to thank my mentors, Dr. Sarvesh Tiwari sir from AIIMS Jodhpur, who gave me a lot of cases for this presentation, and Dr. Bijoy Thomas sir and Dr. Keshav Das sir. And I want to thank the Department of in Imaging Sciences and Intervention Radiology and Department of Neurology of Sri Chitra Institute of Medical Sciences. Thank you.
Thank you, Dr. Smiley, for this excellent review on the infections associated with immunosuppression. So just to start off with the discussion, can you just elaborate or just point out a few infections apart from PML that we need to be careful in patients on immunosuppression in MS, specifically just in MS? You did refer to a few infections in MS, but commonly used medications like natalizumab, we are all very careful with PML. But any other specific infection that we really need to be careful? And one thing which was quite interesting, I noticed in your presentation was the punctate-like lesions in the PML associated specifically with natalizumab. I was not aware of it. So how would you distinguish that from actually an MS lesion? So you showed pontine lesions, which quite much looked like demyelination. So how would you really distinguish them from MS?
Sir, in the early onset of the disease, it is actually very difficult to differentiate the two. But if usually the lesions in natalizumab associated PML will be more in number as compared to an MS relapse, because we have to see in the follow-up MRI. And if they are present at the gray-white matter junction, so usually the lesions of MS will be more well-defined as compared to the PML lesions. Especially towards the white matter side, they will be very irregular, and they will be more towards subcortical location as compared to MS lesions, which will be more in periventricular location.
And possibly the juxtacortical nature of the MS may also be another distinguishing feature. So Netra, any further questions do you have from the audience? Do we have any further questions?
Thanks, Miley. It was a very nice review on all the complications. One of the thing is about you discussed about the PML which starts from the subcortical region. So when you have a person with MS and also PML, so usually we take that if there is a clinical reason, we'll have to suspect. But when a person has, what do you do? Means a person has a worsening, which is a progressive form of MS, and then you also see that there is a lesion which is coming up. So is there any dictum that this is the place you need to look for if you have to pick up PML? If you can just tell.
We will more prefer towards the subcortical regions for PML, whereas for periventricular will be for MS. So this is the main difference which like I have found.
Yeah.
And apart from that, early on it will be very difficult to differentiate, especially if the lesions are very small.
Yes. One of the questions from Dr. Sunil, he asked, is there any difference in prevalence of notch sign on MRI in lymphoma with or without the immunosuppression?
Actually, I read about it. Notch sign can be seen in both lymphoma, in both the immunosuppressed and the immunocompetent status. So it is not that if the patient is immunosuppressed, we will not see. In our case, also notch sign was seen. So it can be seen in immunosuppressed status as well.
Okay.
And he also, I think Dr. G. Nandakishore is asking, what is the reason for those punctate lesions in the PML? Do we know the reason secondary to natalizumab? I would be interested to know that too.
Actually, that much, like, I could not find the exact reason for the why natalizumab is causing that kind of imaging appearance.
Anyone else
But
would want to take up that? Dr. Saini, Dr. Samir, Dr. Ajay, if you people are there. About the punctate
sure.
lesions
I think
which are there in PML.
Ask all the speakers to be there if they are present, just to switch their cameras on.
No, I am not very sure because I have I have read about it, but I don't know what is the exact reason. But there's a morphological appearance probably. We don't really know. Until somebody does a autopsy of a patient who dies of it, then only it will be deciphered out.
Okay. Dr. Ajay, you're there. We couldn't take some questions during that time.
Yeah.
I think you had discussed about all the sequences. One of them have asked as to what are the sequences suggested for orbital cuts in optic neuritis.
In optic neuritis, we should do axial and coronal T2 or star sequence, and then the contrast. But normally now we are doing 3D flare, so sometimes we are not doing a dedicated protocol for the optic nerve. But if patient present with optic neuritis, your first aim is to diagnose optic neuritis, then do coronal T2 or star.
There was another question. Can MTHFR mutation also have ADEM-like picture? So anyone can answer that?
Yeah, they can not like an ADAM, they can show periventricular signal changes. So that becomes a problem. And they can show diffusion restriction as well. So
like MTHFR, usually we investigate them in cases of a stroke, cryptogenic
yeah.
stroke.
Yeah. But
so would this be specific for an MTHFR?
No. It in that context, when we see it,
Right.
yeah, we should see it. So why that case which I showed with the B12 deficiency, same kind of picture can be seen with MTHFR. So what I'm trying to say is the periventricular location lesions, that is also a differential diagnosis in a context, in that context when we are seeing it.
I think this is more described with hyperhomocystinemia, especially when it is genetically caused, and more with frontal predominant white matter. What I remember about this.
Another interesting image which I saw, I think Dr. Sani showed the post-Caskezer. So a couple of cases that we have encountered have had just purely the basal ganglia necrosis and the basal ganglia involvement.
Yeah, that's also a possibility. That also has been described. But what most commonly I've seen with post-cardiac arrest and post these patients, that they develop this and they come after a gap of 2 to 3 weeks. So they develop.
Oh, yes. So I've seen early ones. Okay. So, or maybe it's also probably the magnitude of the exposure. I think that
so because probably carbon monoxide element might be playing a role there. So that is another possibility.
One of the question is on, I know this is demyelination, but MRI between tuberculoma and abscess. Dr. Smiley, you would want to take it?
Yes, ma'am. In tuberculoma, especially it will be T2 hypointense usually because most of the tuberculomas which we encounter will be case-dating granulomas. Then if we are, as compared to the tubercular abscess and both, we can differentiate on the basis of MRS. In MRS, lipid lactate peak will be seen in case of tuberculoma, whereas in abscess, we'll have amino acids and the other metabolites like acetate, so which will not be seen in case of tuberculoma.
Dr. Samir, how to differentiate white matter lesion of neurometabolic disorder and demyelinating disorder? This is from Dr. Akshay.
Yeah. Neurometabolic bilateral and symmetric and are well demarcated, and the pattern which I have discussed. MOG can have like a leukodystrophy pattern which I discussed and carries, that's a clinical radiological diagnosis. So the demyelinating lesion may have a leukodystrophy like, but it's a lot more clinical radiological. So these lesions are uncommon in NMO spectrum disorders or MS, but MOGAD, the leukodystrophy pattern may be seen. So then we have to correlate the clinical and radiological findings. But in a nutshell, the neurometabolic are bilateral symmetrical lesions, which are not seen commonly in demyelinating patients.
Great. Another thing, Ajay, you mentioned about the artifact, which we quite often see. In fact, a lot of our images with the come on a printed image for the spinal cord, the artifact which you didn't mention. So how can we really get rid of that? Not get rid, but while we're looking at the image, how can we distinguish that from a pathological lesion? Within the images that we already have a print, if we don't have the digital image with us?
Yeah, this artifact is seen only in the sagittal images, not in the axial images. So we can do axial images to confirm it first. Right. And then during acquisition also, you can modify the factors increase your matrix size, increase number of acquisitions, averages, that will reduce the artifact. So do the Excel. If in doubt, do the Excel slices to confirm it.
Right. We usually are there along, so we can cross check. Thanks. There's one more question, Netra, would you take it? Yeah.
Yeah. One of them is asked about DVT mimicking demyelination.
Yeah. I think he means deep venous thrombosis, the deep veins of the internal cerebral vein.
Saini showed about ANIC. So I think similar to the deep vein thrombosis for the thalamic involvement.
I have seen one patient in a pediatric infant patients in which there was a branching hyperintensity with diffusion section along the D white matter. So deep medullary vein thrombosis can sometimes show bilateral changes, but they will be more like a branching pattern rather than the multifocal pattern.
Or also SWI will very easily clinch the diagnosis.
Yes.
Look at the SWI images, you will get the diagnosis.
Yes.
And also NEC has got a very what do you call as rim kind of appearance and the central necrosis, which whereas in case of DVT, it will be much more heterogeneous signal changes with the hemorrhages, which are more scattered as compared to more necrotic symmetrical. This can be seen in malaria also, this imaging appearance, which we see in ANEC, but I'm going to say in the context when we are asking, then DVT is pretty easy. If you look at the SWI images, look at the contrast images, pretty easy to diagnose.
And in a deep venous thrombosis, invariably more than 90% of the cases show internal cellular vein thrombosis. So we should look carefully at the internal cellular veins.
True.
I think we'll take a last question because we are due session. What is the differential diagnosis, especially when you have a GFAP-like lesion? What are the other possibilities? Dr. Donna has asked about this, that she had seen a case post-liver transplant presenting with an acute encephalopathy with a similar picture. So what are the other possibilities apart from GFAP?
Lymphoma, maybe a CNS vasculitis. What we see is a perivascular or a linear striate pattern, which we can put up on a neuroimaging pattern. So it can be a lymphoma, means intravascular lymphoma, and we can see such pattern of enhancement in CNS vasculitic acute stages in which there is an enhancement.
One possibility is that patient might be on, it's a liver transplant case, so might be receiving a chemotherapy. So chemotherapeutic agents can sometimes induce a drug-induced vasculitis. I showed one case actually. That's not a drug-induced, that's a drug abuse basically. But drugs are known to cause vasculitis, and then they can have that kind of linear patterns. And they like I showed a case in which but there were big solid enhancing areas was also there, but there was a vasculitis kind of pattern where there was a microbleeds, there was a linear signal going from the ventricles, and there was a linear enhancement pattern going around the way. So it can be drug induced. There's a possibility. So GFAP can be mimicked by a drug induced, especially in this context. What she's talking is more likely to be drug induced because it's a post liver transplant.
Excellent.
Thank you. Thanks everyone. Thank you, Dr. Ajay, Dr. Sami, Dr. Saini, Dr. Smiley, for a very enlightening talk. All of you did very nice justice about your topics, and everything was very well covered from the basics till the last recent advances. Really thanks to all of you. Dr. Dheeraj.
Yeah, and you're right. It was an excellent compendium of all the neuroimaging aspects, right from the basic protocol to the differential between types of demyelination, and then the effects of immunocompromised. I think we covered almost everything. It was like a full book on the neuroimaging and demyelinating disorders and the differential diagnosis. So I thank you all of the speakers. And I think on behalf of the autoimmune subsection, you can close the session, Netra.
Yeah, we have to just announce the results of the quiz. We had a quiz on 5th of July where we had around 169 participants. So based on the results on the topmost, we have selected based on the 4 zones, north, south, east, and west. So can we have the results, please, Asmita? Asmita, you're there?
they're sharing.
Yes. So this is the quiz results. So from the E zone, we have Dr. Debra Das from Bangur Institute and Dr. Rupa Haripriya from AIMS Bhubaneswar. And from the South zone, we have Dr. Sai Kiran from Nizam's Telangana and Dr. Heyman from Osmania. From the North zone, we have Dr. Prachi from AIMS New Delhi and Dr. Milan Mori from RML Hospital Delhi. West zone, we have Dr. Aditya from KM Hospital Maharashtra and Dr. Abhishek from SMS Hospital Jaipur, Rajasthan. Congratulations to all of you. And this is, I thank Dr. Alex and Dr. Neeraj for having carried out this. So there is going to be one more before the last IAN. I think there's going to be one more team which will be selected, and then we'll have the
Yes.
finals in the
That's the
IAN.
wildcard entry, I think,
Wildcard
from
entry.
any of the zones, based upon the their knowledge of all the sessions of the autoimmune subsection.
Yes. So thanks to all the speakers. Thanks to Dr. Dheeraj, to the IAN and the digital team. Thanks to all the attendees who have really attended. Nearly, we had around 176 participants till the last. And thanks to all of you for making this session. Thank you. Bye, everyone. Good
Thank
night.
you. Good night. Thank you. Bye-bye.